Welcome to Cardio Insights, the podcast where we explore how digital solutions are transforming cardiovascular and emergency medicine. Featuring thought leaders from leading institutions across the globe, this series of conversations unveils the power behind clinical algorithms and decision support tools, and how they are changing the way we diagnose and manage cardiac conditions. From their impact on clinical practice, their benefits for patient outcomes, and the challenges they pose to health systems in terms of implementation and regulation, this podcast is intended as a precious resource for healthcare professionals in cardiology and emergency medicine who are curious to learn more about this exciting field. I'm your host, Matthew Chaffert, and you are listening to Cardio Insights. So welcome, Professor Papendick and Professor Daniels, to this episode of Cardio Insights, the podcast where we explore how digital solutions and clinical decision algorithms are transforming cardiology and emergency medicine. So, I feel lucky to have two guests on this special episode. And for, our listeners who might be new to you, I'll give some background on your respective work and focus before we get started with the conversation. So, Professor Papendick, you are an emergency physician at the Royal Adelaide Hospital and an associate professor at the University of Adelaide Medical School in Australia, focusing your work and research on improving outcomes and resource utilization for patients presenting to the emergency department with chest pain, particularly those with suspected acute coronary syndrome. Professor Daniels, you're a cardiologist, director of the Cardiovascular Intensive Care Unit, and professor of cardiovascular medicine and epidemiology at the University of California in San Diego. You have co-authored more than 200 publications in your field where you focus on the use of biomarkers to assess cardiovascular risk in a variety of populations. So in this episode, we want to learn from your experience in implementing and driving adoption of decision-making algorithms and digital solutions in your respective practice, understand the challenges that you have faced in that regard, and get some perspective on what these solutions or where these solutions are heading toward in the future. So the first question that we have for the two of you is, how has the emergence of decision-making algorithms and potential digital solutions changed to your approach to emergency medicine and cardiovascular care?
Well, I guess from an emergency point of view, what we call chest pain pathways, so some of those decision algorithms, I think have been a part of emergency medicine for quite some time now. I guess the most important one has been things such as the heart score. So, and these allow, for example, in the emergency department, it's quite a diverse group of people with undifferentiated problems. And then there's also the staff, who are also a diverse group of people, not necessarily with problems, but a diverse group of people with different interests. For example, some people are more interested in trauma or, ultrasound. So being able to have these pathways allows people to maintain, a homogeneous and evidence-based approach to common cardinal presentations, for example, chest pain. And I think the heart score is one of the most well-known. In Australia, we also have EDACs and things. I think for me, what has changed, and I'd be interested to hear what Lori thinks about this, is that now with high sensitivity troponins, the pathways now incorporate a separate, very complicated troponin algorithm. And then you need to combine all these metrics together in your head, often in the head of an orthopedic, RMO or house officer who is doing, ED for 6 months or something. So not necessarily an expert. And I think we could really use digital sort of algorithms to help calculate some of these more complicated metrics, put them into position with the other things that we get from the patient-specific demographics. And then come up with an evidence-based, approach that's safe for the patient.
Yeah, it's a really good point. I would say, we're not using digital algorithms so much, but we're using algorithms. And the most common one, I would say, is the chest pain pathway, kind of derivations of the ESC 0-1 hour approach. And we started using that when we transitioned to the Gen 5 troponin, to the high sensitivity troponin. as a way to get all on the same page, make sure we're still practicing evidence-based medicine. We were behind the rest of the world in implementing it in the United States, but when we did, we wanted to make sure we had a pathway. People weren't familiar with the test yet, and so we wanted an algorithm to say, look, this is tested not necessarily in the US population, but in chest pain populations. It's safe. We can all be on the same page here. We made a few adaptations until we got comfortable with it, incorporating things like risk scores or high-risk ECGs, and saying it's okay to leave the pathway. If you're uncomfortable, do what's safe. But in general, let's follow this pathway.
Yeah.
And what have been some of the challenges that, regarding in your own practice in adopting these tools or preempting these tools? What were some of the issues, or you mentioned that in the US it came later compared to the other places of the world. So what were certain things that you learned from former implementation that helped you navigate that?
Yeah, I think so. One of the challenges is if we're implementing a 0-1 hour pathway, it's not that common that your testing is exactly at 1 hour. And that's, the life intervenes and the craziness in the emergency department. And I think that's one area of opportunity where digital algorithms can be quite useful, because a digital algorithm can say, okay, well, this sample is really at 90 minutes, and so here's what you want to look for. And you don't need to rely on someone's brain to kind of interpolate for you.
Absolutely agree with that. Yeah. So that by the time a sample is taken, it gets sent off. By the time someone's acknowledging what the sample is, and if it's in a gray zone or whatever, you have these big delays, and we're calculating based on a 0 and 1 hour, at least in my shop. That's the one we use. And often the metrics are different than that. The real world metrics are different. So to have like a digital platform that could do those calculations would be amazing.
I also find some of the beginners, you mentioned you have a lot of people visiting in the ED. We have, new trainees, also people passing through on the cardiology service who aren't necessarily going to be cardiologists, and they don't necessarily understand the gray zone as well. And they think, oh, there's no delta, we're good to go after 1 hour, and they don't necessarily follow the pathway and see, no, if you're in that gray zone, you need another sample. And I think a digital algorithm that said, stop, repeat, would be quite useful for these more complicated situations.
Absolutely. Absolutely.
Do you see a lot of disparities between health systems within your respective country in terms of adopting such algorithms for clinical care, or like the hot score, I assume it's pretty much everywhere? Maybe some more, like you mentioned, next generation troponin. Is it something that's fairly well distributed in your respective health system, or you see a lot of disparities in terms of how these tools are used in clinical care?
Well, it's funny because while we were walking over here, Lori and I were having a discussion about how looking at ACS in particular, from an emergency physician point of view, I want something to be exquisitely sensitive to make sure that when I send someone home, I have full confidence that they've actually ruled out, whereas Dr. Daniels wants to make sure that, okay, I'm taking this person to the cath lab for a reason, particularly if she doesn't have the opportunity to see a patient or to she's trusting me that I'm able to do the metrics to figure out, actually, this is a rule in. So I think that's where sometimes the disparities are. So having a digital thing which could really piece out those intricacies and take into account like other patient characteristics. I mean, for us, you can have a raised troponin in a patient who has a gastrointestinal bleed, let's say, and they're actually having a type 2 myocardial infarction. And really the worst thing we could do, much as I appreciate and respect you, is send this patient to the cath lab. You want this patient to have treatment for their GI bleed because that's what's causing their symptoms. So to be able to have something that would pull in other information like, oh, the hemoglobin is 61. Have you thought about that?
Yeah. And renal function is a big thing, and being able to incorporate all aspects of a patient. If we're thinking about heart failure, another area, I think digital algorithms would be phenomenal because you incorporate BMI, kidney function, and not all natriuretic peptide levels are created equal depending upon the patient who's who's providing
Yes.
them.
And then ideally, maybe you could have a prior one to compare it to. So the ability to have more of these complicated metrics put in together, because I find that often the inpatient teams will overestimate the influence of things like renal function being a problem, and everything's chronic. Everything's a type 2.
That's,
especially at 3 o'clock in the morning. That's how the best way to tell the difference between a type 1 and a type 2 is what time is it. So I think those things could be evened out by digital processes, or at least assisted.
No, Cynthia, that's a super insightful comment, because having prior levels, whether it's troponin or natriuretic peptide for a given patient, is so important for getting a diagnosis and understanding if this is acute or chronic presentation. And I totally agree. That's somewhere where digital algorithms can really be useful.
Yes.
And helping determine a delta, for instance.
Yes.
You mentioned, especially Professor Daniels, that at the moment there were not so many digital solutions available, and you probably also see, in your practice or when you go through even like just the new solutions coming up. Is there something where you would say there is, you have an interest that you would like to have that type of solution at the moment that you don't in your own practice? Or how do you look at these things, maybe from a use case and from an evidence level perspective?
Yeah, so I think two answers there. One, kind of getting also back to disparities in the health system. We do have a lot of differences back in the United States. Not everyone's using high sensitivity troponin yet. And then there's I and T, there's point of care. So when we're a transfer center, a referral center, when we get patients from outside, their troponin that they're sending us is very different from what we're using a lot of times. So a digital algorithm potentially could help to translate that. What would I like to see? I think my biggest wish list would be in the heart failure diagnosis realm, like I mentioned before, taking into account age, comorbidities, body habitus, and interpreting all of that prior natriuretic peptide levels and helping interpret. I think that would be quite useful.
Absolutely, because those other metrics are so important to really doing the right thing by the patient. Like for myself, I get what I consider to be community-acquired acute pulmonary edema, which is when patients who have an underlying heart failure diagnosis come in with their pneumonia. Their BNP is 5,000. What does that mean?
Right.
Well, if you had something that could say, oh, well, last week or 2 months ago, it was, 400, then we know that those things are playing in concert. But we can also pick the right team to look after the patient. Is sepsis the driver? Or do we need a cardiologist to sort out their heart failure?
Understood. And in terms of the level of evidence that you would like to see that supports the use of potentially a new tool that someone would bring to you and say, okay, you need to try that out for either triaging or detecting some of the conditions you work on. How do you evaluate that based on what's available?
There's different metrics, and again, it depends who you ask. If you ask Cynthia, there's going to be emergency department metrics, which I'll let her answer. From a cardiologist point of view, if we're going to be using a metric outside of the ED, we want to make sure that it's improving ultimately outcomes. That's a really high bar, right? You have to show that, hey, using this algorithm is going to make you miss less MIs, improve mortality, reduce hospitalizations. That's kind of a high bar. I think some of the ED metrics might be more attainable. Efficiency in care, efficiency and utilization of resources.
Yes, absolutely. And I also think that there's that zone in between of emergency departments often think, oh, the best thing for the patient is the patient should be admitted. They need to go, and then learning which patients actually would benefit from further intervention versus which patients just need more resuscitation or other bits and pieces that are important to them, and not getting stuck on, oh, the troponin is this, really taking in holistically
Yeah,
all the
yeah.
things that are going on.
Yeah. And I mean, ultimately, from a hospital-wide perspective, if you can make a system more efficient and even save 30 minutes or an hour, you know, that may not be a wow for physicians, but for the hospital system as a whole, it can really be important.
Yeah. Yeah, we talked about that with Professor Than on, you know, the role of digital solutions in addressing overutilization of healthcare resources, especially like in ED. So that's one use case. How do you see, you know, the current and future role of technologies like artificial intelligence in, you know, the development and adoption in a way of, you know, digital tools in clinical practice? Is there like a use case that you think of when you think about these technologies in your respective areas?
We're seeing, yeah, I think there's a lot of potential there. We have to be careful to implement it, you know.
In the correct way.
Yeah, in the correct way where we know we're doing good. But there's already, you know, interpretation of electrocardiograms, for instance. And if you could merge that with biomarkers, I think that could be extremely useful. But even interpretation of ECGs, like there's a lot of what we call ST elevation myocardial infarctions, occlusions of the arteries that don't actually have ST elevations. And if you incorporate that with AI, plus or minus biomarkers for the non-ST elevations, and it could really improve efficiency and potentially improve outcomes as well. 100%,
I agree with that. I think that one of the things I find when I look at an ECG is you get the computer printout, which I tend to, you know, I ignore it at my peril. If it says acute MI all over the top, you know, you want to have a look, but often it'll say things that don't seem to make a lot of sense. So you really spend your time. So it's based on my ability to assess that. And as you're saying, acute myocardial infarction with an OMI, you know, with an acute occlusion MI, because ST elevation is very common and it's not always an occlusion. So being able to discern those subtler changes of posterior MIs or different changes in T waves, which are very subtle, if you're not interested in ECGs, people are going to, you know, people miss it.
Yeah, and I feel like that's
just that's where AI, because I've always been disappointed with the computer interpretation of ECGs, you know.
I'm kind of in shock with how bad it is. It's part of the reason I have a job. Like one day a week, I'm sitting there reading ECGs and overriding them. But that seems like low-hanging fruit that could get better pretty quickly. And then you take it the next step and you incorporate that ECG with your digital pathway for chest pain, and you could really improve things.
Because most of the pathways that we have now don't really include ECG. Often ECG is sort of tossed aside as either ischemic or not. And it's like there's a lot more in there.
I think there's a lot more in there.
So I think we're losing a giant amount of information about what's going on.
I think it's an interesting segue for the recurring question we have across all the different episodes, which is, and you already, you know, expressed some of the wishes in terms of what solutions you would like to see, but if you had a magic wand, which would be like one digital solution you would like to have in your clinical practice that you think is very missing at the moment?
I would say I would love to have
ECG
better and more reliable ECG interpretation. I mean, I think the key thing with ECGs is that it is interpretation, because literally I could look at ECGs and then 5 other cardiologists look at, and you'll get 12 answers. Do you know what I mean? So I think it is still interpretation. It needs to be taken in the clinical context. But if you had some algorithm that would be able to say, you know, consider these, you know, this ST depression in this thing, is this a high lateral problem? You know, that kind of a thing that people often miss. So just to consider that this is there, it should be able to,
and I mean, I agree with Professor Papendick, and at the same time, we have to realize it's kind of the contrary opinion in the world of biomarkers, right? A lot of these algorithms don't even incorporate ECGs, but as a cardiologist, I'm uncomfortable with that. And an algorithm could tell me, oh, low risk, send them home. But if I'm seeing dynamic, you know, down home ST changes, I don't want someone ignoring that patient. So I agree 100%. Even though it's not a popular opinion necessarily.
Perfect. Thank you so much. Thank you for listening to this episode of Cardio Insights. We hope you enjoyed it. If you want to dive further into other aspects of digital solutions in cardiovascular and emergency medicine, check out the other episodes of the series. To support the show, you could share this episode with your surroundings and leave a 5-star review on your preferred streaming platform. Cardio Insights is a podcast brought to you by Roche. Thank you for your time and see you in the next one.